Now?
Yes. Yeah.
Perfect. Well, welcome to you all. And as Katja was telling, I am a veterinarian. Well, it's even since more than 25 years nowadays. But I'm not a scientist. So today I will take you through this trial that we do in cancer immunotherapeutics. And I hope I will be able to answer all your questions at the end. But when it's very technical questions, I might have to come back to you later after discussing with the group. As the title states, we are going to talk about the polyclonal antibody therapy. When nowadays there's discussion or there's a talk about immunotherapy, most often it's about monoclonal antibodies. Well, we know PD-1, PD-L1, but this is clearly a different approach. And so first, I'm going to take you through the roads, how we came to this approach, and which steps we took there. And in the end, I will show you the results of 2 trials that we have been conducting with this treatment option. The most, well, the largest and the oldest one is with the canine transitional cell carcinoma of the bladder, but also I will show you some preliminary results of the trial with osteosarcoma. Well, when we look at cancer therapy, we all know there's still very much to learn there. When we look at the human numbers, there's more than 12 million deaths per year. Oh, sorry, something's going wrong here. Let's try again. Can you... Let me see if I come back in here.
Yeah.
Yes, this back again?
Yes, it is. Thank you.
Luckily. Yeah. So still we have quite a lot of cancer deaths each year, despite all options we have nowadays. And another thing is that treatment of cancer is also a burden to the patients. And especially in our veterinary patients, that's always the worry of the owners. Is my animal not going to be suffering from the treatment? Why do we still have so many deaths in cancer therapy? Well, that's we all know sometimes, well, most often resistance occurs and thereby relapses occur. We do know that the vasculature of tumors might be an interesting target, and we also have some angiogenesis inhibition therapies, but what we have now is quite a limited effect and also quite a temporary effect. On the other hand, the solution might be in the tumor vasculature. And what we found out is that in tumor vessels, very specific markers are expressed. And the good thing about that is that those markers are expressed over a great number of tumor types and in all tumor stages. And so it's not specifically for one tumor, one type in the vasculature. No, in the vasculature, the markers are the same over many different tumors. So when we can target that, we can treat many different tumors with one therapy. Again, we already know that it can be effective, but in the moment it is only a very short effect. Let's go back to how angiogenesis works. We have a dormant tumor that starts to secrete the angiogenic cytokines and thereby activating the endothelial cells, and they start to proliferate and produce proteases. And so they are... Can you also see my pointer?
Yes.
Yeah, okay.
Mm-hmm.
So there we can see the start of the sprouting of the vessels, and then the vessels grow into the tumor, and in the end they vascularize the tumor. And then not only the tumor will be fed through the vasculature, but also the tumor can use the vascular structures to metastasize to the rest of the body. At this moment, we do have monoclonal antibodies in the human medicine. It's called Avastin, and it's directed against VEGF. And as the vasculature shows very promising, when you look at the result, it is, well, quite a little bit disappointing. There is an efficacy, but only when you combine it with chemotherapy. And what you see here, the red line is chemotherapy plus placebo. And here we have chemotherapy plus Avastin. And you see the difference. In median survival time is only 3 to 4 months. And that's because in due time resistance will occur and the therapy will no longer be effective. So we have a limited gain in survival time at the cost of serious side effects that are seen, like blood clotting, proteinuria, and also the treatment is quite demanding for the patients. A human patient has to be hospitalized for the treatment and get an infusion during several hours. So that's not very promising at the moment, but then what is found that when you combine these antivascular therapies with immunotherapy, it's much more effective. And so there is an opportunity there. Well, I'm going to try to explain this slide to you. Again, I'm not a scientist, but I will try. Normally, when we have a T-cell mediated cell killing, of course, we have the T cells, they need to attach to the vascular wall, get out of the vasculature, attach to the tumor cell to be able to have their effect. On the top of the picture, we see the function of PD-L1 in that reaction of the T cells with the tumor cells. And we know that's the immune cycle blockage that's there. And when we give immune cycle checkpoint inhibitors, then we can contradict that, and then the cascade runs further and the T cell can kill off the tumor cell. What's less known is that when the tumor cell produces the pro-antigenic cytokines, the expression of adhesive molecules like ICAM and VCAM in the endothelial cells is suppressed. And thereby, when there are no adhesion molecules in the vasculature, the T cells cannot adhere to the wall and cannot get out of the vessels to do the killing. When we treat with anti-angiogenic agents, then there is a re-expression of those adhesion molecules. The T cells can adhere to the vascular wall, and then they can go out of circulation and go to the tumor cell and kill those off. So we need new angiogenesis inhibitors, which are as effective as we have now with the Avastin, but with not the problems of the fast development of resistance. And there starts the story of this immunotherapy. What has been done is by RNA sequencing, we have looked at the gene expression of endothelial cells. And we looked at the endothelial cells of adults and looked at which genes are active in the endothelial cells of adult animals, which genes are active in embryo vascular endothelial cells, and which genes are effective in tumor vascular endothelial cells. And when you look at those three groups, there is a group of genes that is active in the embryo vasculature and in the tumor vasculature, but not in the adult vasculature. And so these genes are possible targets specifically for tumor vascular endothelial cells. By this screening, we have found 10 possible targets, and we started with the two most promising, and for the record, they are called CP1 and CP2. And when we looked at CP1 and we checked in 23 different cancer types, it was found that in all those cancer types, it was overexpressed. In many tumors, it was very strongly overexpressed. In others, it was mildly overexpressed. And the trioid and the cervical are, well, just a little overexpressed, but still there's an overexpression. And when we looked at this is in human tumors where they looked for it, and we see that those 23 cancer types, well, they together they represent more than 80% of all malignancies. And so a very, very large group of tumors express CP1. CP1 is the same as vimentin, and we all know, probably have heard of vimentin, and we know that it's expressed in a lot of cells. And as you can see here cells are made permeable for the dye, and then you can stain for intracellular vimentin. And so these are positive cells with intracellular, lots of vimentin, and in negative cells you don't see any staining of vimentin. However, what we are talking and what we see in those tumor vasculature is extracellular vimentin. In this picture, cells are not made permeable for the dye for vimentin, so we cannot see intracellular vimentin, but we see a lot of extracellular vimentin. And this is therefore also very available for an immune response. So with the sequencing, we determined what are the possible targets, and then of course we have to validate those targets. And first thing what we did is for vimentin, we took a commercial monoclonal antibody against vimentin, against CP1, and we gave that in 2 doses to the mice. One was 1 milligram per kilogram, the other was 10 milligram per kilogram. And of course, we did also a control with an antibody to an antigen that was not expressed in these tumors. And when you look at that, you see that the monoclonal antibody against vimentin was very effective in slowing down the growth. Already at the dose of 1 milligram per kilogram, the tumor growth was diminished by almost 70%. And when you go up to 10 milligrams per kilogram, it was almost 90%. And so hereby, we also validated that targeting vimentin was effective. Then the next question, why would vaccination be better than just treat with a monoclonal antibody against vimentin? And when you vaccinate against vimentin, you will get a polyclonal antibody response. And it has been shown that polyclonal antibodies neutralize better than just monoclonal antibodies. Secondly, when you vaccinize, then you get autologous antibodies, which are known to penetrate better than humanized, or in our case, dognized or catnized antibodies. Another advantage of vaccination is that you can also add different antigens in your vaccine, thereby getting a production of different antibodies. So you can do multiple targeting in one vaccine. And that's what we are doing now. Furthermore, and that is important, not only for human patients, I just told you in human patients, when you get Avastin, you have to go to the hospital, be there for several hours to get your infusion before you can go home. Well, a vaccination theoretically could be given just by the general practitioner. That same goes for our patients. When we would have to keep the patients in our clinic for several hours to get an infusion, that would be for many owners very big decision. While now the owners come, it's just one intramuscular injection and you're done. And so it's much less invasive. The previous slides shows that with the current monoclonal antibody Avastin, we get efficacy for about 3 to 4 months, and then we get the development of resistance. And I will show you later that with the vaccination, we see a much longer efficacy in terms of months. And not important for human medicine, but especially for veterinary medicine, where the owner has to pay for themselves, it's much more cost effective. But when we want to vaccinate for, in this case, Vimentin, we are vaccinating to a self-antigen. So that is difficult. How can we pursue the immune system to make antibodies to a self-antigen? And that has been done by when we constructed the vaccine protein. It's consisting of 2 parts. One part is the self-antigen, in this case CP1 or Vimentin, and it's conjugated to a foreign antigen. And in this case, that's bacterial thioredoxin, a TRX. And what is happening then is that the antigen-presenting cells and B cells take up the vaccine protein and express both peptides, so self and foreign antigens. And then the T cells, the T helper cells, recognize the foreign peptides and thereby helping the specific B cells to proliferate and produce the antibodies, which in this case will be polyclonal. So when we vaccinate, there are several things. We have the antibodies. Because of the antibodies, as we saw earlier, now the T cells can adhere to the cell, to the vascular wall, and extravagate and go into the tissues. And we have activation of complement. So we have 3 mechanisms of action: the antibody-depending cellular cytotoxicity, complement, and also the effect of the antibodies itself. And here we can see how a killer T cell kills a tumor cell. I always think those films are quite impressive, how we can visualize that. But when we vaccinate against self and non-self antigens, we also will get antibodies against both self and non-self antigens. And for our immune response, we just need the self-antigens, the antigens against the Vimentin. So in order to see that how can we get more self-antigens, people have looked at the TRX and reconstructed that in a truncated form. And when we make a picture of that, we see that the TRX is smaller, the structure is changed. And by changing the TRX in this way, that is called the iBoost technology, we see that less anti-TRX antibodies are produced. You can see that here, much less of the non-self antigens of antibodies are produced, and the production of anti-self antigens, anti-Vimentin antibodies is much, much higher. And in mice models, we found that almost 5% of all EGG was antigen against our Vimentin, our vaccine. So now we have determined the target. We have determined that it's a good target with the monoclonal antibody, and we have constructed our vaccine to stimulate the immune system. And so now is the time to show that also in the clinic it works, and therefore we started with mice trial. And the first trial was in mice with colorectal carcinoma. And so they were vaccinated 3 times, and then the tumor cells were injected. And what we saw is a clearly reduction in growth rate. All the animals produced a high number of antibodies, leading to a high antibody titer. And we also wanted to see, well, what's the effect on the animal itself? And one of the ways to look at that is body weight. When the animal is not feeling well, it might eat less and lose some weight. And we didn't see any change in weight when we compare the control, the placebo group, to the vaccinated group. So this was the first success. Then, as we stated, that vimentin is expressed in many different tumor types. We went to the second tumor, and therefore it was chosen to use melanoma. So here, the same study, but now after vaccination, the mice were inoculated with melanoma tumor cells. And we saw the same results. So we saw inhibition of growth. All animals had a high antibody titer. And again, we didn't see any change or difference in development of weight between the placebo group and the vaccinated group. Then the next step was to determine what is the effect of the development of metastatic disease. And so this group of mice was again first vaccinated against vimentin, and then in the carotid arteria we injected the melanoma cells. And again, high antibodies, and very interesting, when we then looked in the brain, we saw a 20 to 30 times less metastatic formation in the brain of those mice, and thereby implicating that also the development of metastatic disease was inhibited. So good targets, good vaccine, and also proven effective in our mice models. Then the thing still open was safety. And so in this study, we looked at the long-term toxicity of the vaccination. And here, what we have done is we have vaccinated the mice according protocol. So you have your basic vaccinations and then your booster vaccination. And what we saw in all animals, after the basic vaccination, you start your immune response and you see the antibody production. And when it got low and you give a booster, again, you see the antibody titer going up and going up again. And in this whole period of 45 weeks, so that's really a long period, there was no difference in body weight, behavior, and also not in pathological histological examination after euthanasia between the control group and the vaccinated group. And so this says, well, it seems to be a safe treatment. When we screened for the targets, we specifically screened for the genes that were not active in adult animal vasculature. But still, you want to prove that there is no effect on forming of new vasculature, and wound healing is a good model for that. So as an extra test for safety, we compared mice in which we made a wound and we were just giving the TRX, or we vaccinated them, and we see there is no change in wound healing. So thereby proving that the vimentin, extracellular vimentin, is not there in healthy vasculature in adult animals, and there's no negative effect of the normal neovascularization. And so now we have the target, we have the vaccine, we have proven efficacy in the mice studies, and we have seen that it's safe. So now we could go to dogs. And we choose the dogs with TCC of the bladder, and because, well, we know we do not have a very effective therapy for that cancer. We have the NSAIDs, we have vinblastine, we have other chemotherapeutic options, but still survival time is reasonably low. We do not have any alternative. And so we chose for dogs with TCC, and I started that study when I was still working in Gouda more than 4 years ago, and I took the trial with me to Nieuwegein. And these were client-owned dogs with spontaneous cancer, and they had all muscular invasive disease. So how did the treatment look? Well, when we looked at the mice, you saw that after 3 vaccinations, the antibody titer went up. So we decided that we would start with 4 basic injections, so every 2 weeks. So at week 0, 2, 4, and 6. And at every time we also took a blood sample to check for the antibody titers. And surprisingly enough, whereas in mice it took 3 vaccinations before we saw some antibody production, in dogs we sometimes already saw that after 1 injection, and in almost all dogs already after 2 injections. But this was the protocol, so we followed that. But as you can see here, after 3 vaccinations, all dogs had a high antibody titer. After the basic vaccinations, we did booster the dogs every 2 months, as you can see here. And we did that as long as the dogs were well. So this is a picture of Benno. Benno is a Bernese mountain dog, which was our 2nd patient. And Benno had an enormous tumor in his bladder. And when Benno came to us, he was already 7 years old. And the owner were very motivated. So we start with the vaccinations. But the tumor of Benno was over 8 centimeters. And the problem of Benno was that at week 6, the tumor was, he had very much blood loss with the urine. So that was the reason that we did go to surgery. And so it was not because we want to cure him. No, it was just because of the blood loss. And thereby you see the line going down. With Benno, you can see we treated him very long. And in the end, Benno lived for over 3 years. And in the end, died of unrelated renal failure and not of his tumor. In all that time, the tumor did reoccur, and in the end was 3 centimeters big. But what Benno did not develop was metastatic disease. And besides the results I will show you on the tumor itself, that was another conclusion that we could draw. We see much less metastatic disease in our vaccinated dogs. Another dog we saw, and in this case, we saw a complete response. That is one example, but from all the dogs we treated, I think we only saw 2 or 3 complete responses. Most dogs had a partial response that lasted for a very long time. In the end, leading to a median survival time of over a year in our first 20 patients. Of course, that's a good result, because these dogs only get the vaccination and the COX inhibiting. Most of them were on Metacam. But also we did see metastatic disease in less than 10% of the dogs. And the dogs that did die of tumor-related causes did die because of local disease and not of metastatic disease. On another location, there is also a study done in dogs with osteosarcoma. Again, blind-owned dogs with osteosarcoma. And we all know normally when we do surgery and chemotherapy, we have a median survival times of, well, less than a year. When we only go for surgery, it's much shorter. In this study, dogs were allowed to have the amputation. Without amputation, they did try that in the beginning, but the results were not good. But for the rest, these dogs were of owners that did not want to proceed with chemotherapy. And so these dogs only had their leg amputation and vaccination. And at the moment, 24 patients are enrolled, and the median survival time at this moment is almost 300 days. And so that's just with amputation and vaccination, so no chemotherapy here. So this looks very promising. Of course, we need more numbers, and of course there will be a follow-up study also combining the chemotherapy with the vaccination to see if we can even further improve these results, but this is very encouraging. Because of the encouraging results, we at this moment also started with a study in hemangiosarcoma and oral melanoma, but there are only a few patients enrolled at this moment, so I cannot give you any reliable results of that yet. Furthermore, in the beginning I showed you that we have found 10 possible targets, and vimentin was the first target. Now we are completing the same study in bladder tumors with a second target, which is called versican, and we see there that we see less of a partial response, but a longer stable disease leading to a little longer medial survival time. And those results will be ready in the next few weeks and be presented at the ESFONC in Porto by my colleague Lopke van Bergen. In my studies, we have identified an even more promising target, which in mice give even, well, very much better results than the first two targets, vimentin and versican. And we hope to start with the study with that vaccine in the coming 2 to 3 months. So if you have any patients, and well, some of you will be probably far away from the Netherlands, but don't hesitate to contact me to see if we can figure something out. So when we look at this study, what are our conclusions? We can say that targets that we have identified are specific for tumor blood vessels, but are expressed across many different tumor types, making it very effective in treating many tumors. And we have seen that the vaccine that we use induces high effective immune response with high immune titers against the tumor vasculature, and we have shown that it inhibits the growth and also the development of metastatic disease. And even more important, the only side effect that we have seen, and I think at the moment we have treated more than 60, 70 animals and delivered more than a few hundred doses, and the only side effect we have until now is a painful upper arm after vaccination for the first 2 to 3 days. We also have seen that it gives a long-term effect, in contrary to the Avastin that we see in human medicine with only 3 to 4 months. We see long-term efficacy. And it only uses a very low amount of biomaterial. We only need the vaccine, and then our body will make the large amount of antibodies. And because of it's just being an intramuscular injection like any other intramuscular injection, it can be applied much more easy than the long-lasting infusions with the anti-angiogenic medications as known in human medicine at this moment. So. In the end, I want to thank, well, you can see it's a big group, but especially Professor Dr. Arjen Griffioen was very helpful in explaining to me what the principle of our treatment was, and also helping me with making this presentation. The same goes for Dietrich Engsbergen. If you want to know more about the vaccine, there is a very informative website from SimCure. That's the group working on it. And if there are any more questions, I am happy to answer them.
Excellent. Thank you so much, Arno. I'm sure there are lots of questions, but maybe I can start. So, of course, I'm really interested in what are the costs of treating a dog with, there will be several injections.
Yeah. Well, at this moment, of course, it's a trial.
Yes.
So most of the cost of the vaccine are also taken by the trial. So at this moment, the cost for the owners will be around 1,000 to 1,200 euros for the first period of 8 weeks with the vaccination, the basic vaccinations. And after that, it's about 250 euros per 2 months.
Okay.
And the results of this first study were so good that a company there's a startup, and it's named after the Bernese mountain dog that we just saw, Benno. It's Benno TX, so you can Google that and you can find it. They are now going the way to register it for veterinary use.
Right.
And Arjen Griffioen is the brain behind the principle, and he is very in control about what's happening. And one of his firm demands was, if it's going to be on the market, then the cost of vaccination, so that's of course without consultations, ultrasound, must be maximum about 1,000 euros per year.
Yeah.
And so I think it's very affordable, and of course your ultrasound is coming to that, your consultations, but
it's, I mean,
more expensive than a chemotherapy for lymphoma dog.
Oh yeah, and it's much more affordable than CAR-T therapy, for example, that has been used on the human side for some cancers. So yeah, definitely. The other question I had about, because you said that there were a couple of dogs with complete response and then quite a few with partial response. Was there a difference in the cancer staging between these groups, or between the dogs who didn't respond and these?
Of course, the one that were in complete remission were the smaller tumors.
Yes,
that for sure. I would say that with this vaccine that we were discussing here, the Vimentin vaccine, I would say that quite a lot we saw that partial response stabling out, and then very slow progressive disease leading in the end to that survival time of over a year. When we first started with the second vaccine, I was less enthusiastic because I didn't see that partial response. I only saw stable disease. But when we looked at the data later on, we saw, it's a stable disease, but it lasts longer than with the first vaccine when we first had the partial response and then the progression. So in the end, and again, Lopke will tell you about that in Porto. In the end, the results of the second vaccine are better when you look at survival time, because we are able to get a very long stable disease situation.
Yeah, I'm really looking forward to Lopke's presentation at this year's SWONC in May. also, you mentioned that there were other targets as well. So do you have any idea of the timeline? So you're running these phase 1 clinical trials for the first target, also in osteosarcoma and hemangiosarcoma. Did you say also in melanoma, oral malignant melanoma?
Yeah.
And then also running trials on the second target. What about the other ones? Are there plans to test those as well?
Yeah. For now, and what we do want to have a significant a group big enough to have significant results. So for now, the plan is to, I think in the bladder patients we see the most, and we have the most experience. So probably what we will do is use those bladder tumors to go to different targets, and there select what's most effective, and that roll out that one to the other tumors.
Right.
So
yeah.
now we have completed the second group with the versicon, and we will start with the third group in the coming 1-2 months.
Yeah.
And within bladders.
Yeah.
And even more maybe interesting to mention is that because of the results we had in our dogs, by now, I think by the 1st of June, also the first human trial will start in the Amsterdam hospitals with the same vaccine.
That's awesome.
Our data to get permission from the ethical commission, and they say it saved them more than 2 years by doing the dog studies. So that's also a motivation for many owners to know that they contribute also to human therapies.
That's absolutely fantastic to hear. Yeah, that's really cool. I'm also really excited about this, of course, because we are developing these diagnostic tests. So I'm hoping that in future we can combine. We will discover cancer earlier, and then because it's discovered earlier, it's even more treatable. So
that might be a good combination when you caught it earlier, and then you can target the vasculature. That might be very promising.
Yeah, absolutely. I can't see any questions from others. We've previously tried to use the Q&A button under in the bottom right-hand corner. It didn't work very well. I'm wondering if the chat works. So if someone can try that, and maybe one of my colleagues is here, and if it doesn't work, please send me. Okay, I got a message. It doesn't work. Brilliant. This is a recurring problem.
Well, if any questions occur, if people reach out to you and you report them to me, no problem at all to answer.
Yeah, please message me or please message Arno directly. I think we can end this session. It was a real pleasure listening to your results, and so exciting times for canine oncology. So really looking forward to the talk in May, and here's to many new discoveries in the coming years.
Well, I hope everybody enjoyed